All right, let's jump right in. Today we're tackling something we see behind the counter literally every single day: dyspepsia. We're going to walk through this from a pharmacist's point of view, the whole journey from that first patient conversation to the nitty-gritty of long-term medication management.
So here's how we're going to break it down. First up, we'll make sure we're all on the same page with the definitions. Then we'll get into the really critical part, spotting those red flags. From there, we'll dive into the test and treat strategy for H. pylori, get comfortable with the main treatment regimens, and then we'll wrap it all up with some key counseling points that go way beyond just the first prescription. Let's do this.
So why is this such a big deal? Well, look at this number. About a quarter of all people will deal with dyspepsia in any given year. That is a huge number of patients coming to us for help. Just walking up to the counter looking for some relief. So being really sharp on this topic is absolutely essential for our practice.
Okay, first things first. Before we can treat anything, we've got to be speaking the same language, right? A solid foundation here just makes every decision that follows way, way clearer. So the textbook definition of dyspepsia is pretty straightforward: pain or discomfort up in the upper abdomen. But you know as well as I do, patients don't walk in quoting textbooks. They're going to talk about feeling bloated or nauseous, or that they get full way too quickly after eating. Our first job is hearing those complaints and recognizing them as potential signs of dyspepsia.
And this right here is a really, really critical insight. While our minds might jump straight to ulcers, peptic ulcer disease, the truth is that's only found in about a quarter of cases that actually get scoped. The vast majority, we're talking 3/4 of the time, is functional dyspepsia. That means they have all the symptoms, but when you look inside, everything's normal. It's a massive distinction that totally changes how we approach most of these patients.
And that distinction leads us directly to our most important job at the counter: the initial triage. This is where we, as pharmacists, play such a crucial role in figuring out who we can help and who needs to see a doctor, like right now.
So this is it. This is the big question we have to answer right off the bat. Do we suggest an over-the-counter option and tell them to see how it goes? Or do we stop everything and say, you need to see your doctor immediately? And the answer to that question is all about spotting the red flags.
And here they are. I can't stress this enough. If a patient mentions any of these alarm symptoms, the conversation changes. New symptoms and they're over 60, losing weight without trying, nonstop vomiting, signs of bleeding, any of these mean our one and only job is to refer them for an immediate investigation. This is fundamental to keeping our patients safe.
Okay, so what about that big group of patients, the ones under 60 with no alarm bells ringing? Well, for them, the guidelines are super clear, and they point us in one very specific direction. And it all revolves around one very particular and very pesky bacterium, Helicobacter pylori. And here's the why behind that strategy. In Canada, about 30% of patients with dyspepsia will test positive for H. pylori. Because that number is pretty significant, the most cost-effective approach is what we call test and treat. We test for it, and if it's there, we treat it. Simple as that.
So how do we test for it?
Well, there are two main non-invasive ways. You've got the urea breath test, or UBT, and the stool antigen test. Both are really good, really accurate tests, but their accuracy depends entirely on one critical factor that we have to counsel our patients on.
And this right here is maybe one of the single most important counseling points we can give in this whole process. To avoid a false negative, the patient absolutely must stop their PPIs or H2 blockers for at least a week. And even more, any antibiotics or bismuth have to be stopped for a full month before the test. If they don't, we could miss the diagnosis, and that's a huge problem. We need to be proactive about this.
All right, so let's say the test comes back positive. Now what? It's time to talk about eradication therapy. Let's look at what the Canadian Association of Gastroenterology recommends as the first-line treatments.
Okay, the standard is 14 days of quadruple therapy, and we've got two main players here. For the clarithromycin-based one, you need to warn your patient about the high pill burden, the chance of a weird metallic taste, and this is critical, absolutely no alcohol with the metronidazole. For the bismuth regimen, the dosing's a bit more of a headache. The big thing to prep them for is that their stool and tongue are going to turn black. You have to tell them this is totally harmless and expected. That one little tip can prevent a whole lot of panic and keep them on their treatment.
But hold on, our job isn't done just because we've handed over the prescription box. We've got to be medication experts, right? That means looking at the patient's whole profile, especially their other meds.
And here is a classic scenario we see all the time: the patient with dyspepsia who is also on an NSAID.
And don't forget, that includes low-dose aspirin for their heart. This combination is just a major setup for peptic ulcer disease.
So who actually needs that extra protection? Well, the guidelines give us a pretty clear checklist. If your patient is over 65, on high doses of NSAIDs, or taking them along with things like steroids, blood thinners, or even SSRIs, they're at risk. This is something we should be actively looking for every time we dispense an NSAID and starting that conversation about adding a PPI for protection.
And speaking of PPIs, this brings us to a huge topic in pharmacy right now. It's this long-term, sometimes seemingly indefinite use of these drugs. It's really on us to be good stewards of appropriate PPI use.
You know, this quote from the Canadian Association of Gastroenterology and Choosing Wisely Canada just nails it. They are flat out recommending that we reevaluate PPI therapy every single year. And who's in the best position to start that conversation? We are. Every time a patient comes for a refill.
It can feel a bit daunting, but here's a simple 3-step game plan you can use in your practice. Step 1, identify those patients on long-term PPIs without a clear ongoing need. Step 2, discuss it. Talk to the patient and the prescriber about the pros and cons of continuing. And step 3, plan. If everyone agrees, help create a plan to taper down, switch to as-needed use, or stop it completely, with a solid plan to manage any rebound symptom.
So I'll leave you with this to think about. It's interesting, isn't it? For decades, the big challenge in this field was finding an effective cure for ulcers. But today, as we manage dyspepsia for millions, maybe our greatest challenge has shifted. Maybe now it's about the wise and safe stewardship of the very medications that brought us that cure. Thanks for tuning into this Explainer.